A very warm welcome to our webinar, the first in our winter series structured around the Venus model for workforce transformation and involving colleagues from the International Practice Development Collaborative. My name is Kim Manley and I am Professor at Impact in Practice Development and Co-Director. I'm joined by my colleague Irina Anna Frey from the Swiss Practice Development Network for the University Hospitals at Basel, Bern and Zurich. We're also joined in spirit by three colleagues in Australia, Dr. Beck Middleton from the University of Wollongong and Chris White and Simone Clark from the Sydney Children's Network. It's nearly midnight in New South Wales, so they have valiantly contributed audio and video recordings, which has tested our IT skills. We are hoping these aspects will proceed smoothly, following the invaluable help of our colleagues at UEA, Heather Judson, Bianca Bianchi and Mel Kidd. Should we experience any challenges with the audio sections, we will ensure you are supplied with a copy of the complete PowerPoint. In addition, my Impact colleagues, Associate Professor Carrie Jackson, Professor Jonathan Webster and Dean Professor Sally Hardy are on hand to help with processing the comments raised in the chat box and helping to make sense of them. We intend to complete our presentation in approximately 35 minutes and then spend the remaining time working with your comments, questions and observations. Thank you. For those who attended the launch webinar for Impact in September, you will have been introduced to the Venus model for sustainable person-centered transformation. For those who are new to the model, the Venus model is a unifying framework based on practice-based research with frontline teams and identifies the 5 essential skill sets needed for sustainable person-centered transformation. The first skill set is practice development. And this is the focus of today, although all the skill sets are interdependent and we will touch on all of them today. However, further detail about the 4 other skill sets will be provided in more depth in the remaining webinars in this series. You may find it useful to have some questions in mind during the presentation. Some are included here, and these also reflect the interdependence between concepts in the Venus model previously identified. Focusing on practice development as a concept, we will first provide a brief overview of the theoretical development of PD before bringing you right up to date with the PD Global Manifesto and its linked principles that frame our presentation with examples of their impact. So what is practice development? The answer is simply reflected in the purpose of our Impact Research Group here at UEA. Although this purpose would be aspired to by many, practice development emphasises co-creation with people based on shared values and integrates practice with learning and inquiry or research, rather than on people. The title of the seminar suggests that it is how you do practice development that differentiates it from other approaches. A second fundamental difference is that it is driven bottom-up by health and social care practice and what matters to people. It is at this level that health and social care is both provided and experienced by service users and citizens. Whilst PD is a global movement now, with increasing multidisciplinary relevance, it is important to recognise its roots in the nursing development movement of the 80s and 90s in the UK, when nursing development units were set up and led the way in innovation around person-centred care, particularly with regards to older people. Prior to this time, PD often embraced innovative initiatives introduced into practice that positively changed practice but were not sustained and did not influence policy because they were neither formally evaluated or researched. It was this context that acted as a driver in the very first research excellence framework in the UK, which enabled a concept analysis of PD to be completed. This led to practice development becoming a specific methodology and a search term in the key library databases. During this period, practice development was introduced to Australia through extension of the PD schools held in and across the UK, and an international practice development collaborative was established. In 2006, a realist synthesis was completed, funded by Nursing Education Scotland, that identified implicit principles and eclectic methods used within practice development, such as values clarification, observations of practice, stakeholder evaluation, critical creativity, to name but a few. This research paved the way for identifying 9 principles of practice development in the first edition of the International PD textbook in 2008, strongly influenced by critical social science, associated with the British philosopher Brian Fay and his 3 E's: enlightenment, empowerment, and emancipation, which describes the process of how people are freed from oppression. Not from class war as advocated by Marx, but through the role of reflection, where there is attention given to our assumptions and the aspects of practice we take for granted, as these often constrain our thinking and actions when trying to make changes on our journeys of transformation. These 9 principles also describe PD as a complex intervention. In the second edition of our International PD book for Health and Social Care, awaiting imminent publication, includes a review of these principles to generate a global manifesto for PD. You will hear more about this shortly from Irina Anna, but before this, the next slide accentuates the key concepts embraced by practice development. On the left-hand side, the original concept analysis is presented. At the heart, you will have the development of a person-centered culture, initially referred to as being patient-centered, but the theoretical and philosophical focus changed quickly to a person-centered approach of particular relevance now to embrace staff as well as service users. The next concentric ring focused on transforming individuals and contexts of care, the outer ring on shared values and vision. These foci were achieved through the 2 sets of processes: skilled facilitation, which later was strengthened with the concept of active learning in and about practice, and authentic engagement with people linked to systematic evaluation. On the right-hand side of the slide, the macro structure of the new Global Manifesto is presented, in which the original key concepts are still central. The manifesto is structured around PD foundations, processes and outcomes, and is used to frame this webinar. Irina Anna will explain its development and content in more detail.
In the slide above, we have seen the revised PD principles in a new order. You might have noticed that there are now 8. I will briefly outline the review process. IPDC members, and I was one of them, were invited to review the 9 PD principles first published in the International PD Book 2008, as Kim already mentioned. The graph on this slide shows the timeline of the stakeholder review process. Working together, we ensured PD methodologies were used throughout, with each facilitated meeting using PD principles of collaboration, inclusion and participation. 7 IPDC members from different countries were involved, and we decided on our first meeting that we would use methods taking into consideration what feedback strategies would work best in our local contexts. We agreed on a set of questions to stimulate discussion and critique. We captured feedback from 184 persons across a variety of stakeholder participants. 2 themes emerged. Theme 1: accessible language. Language was a big issue in the feedbacks. Some people felt the language was overpowering or not easily accessible, and others asked, what does person-centered mean? What does human flourishing mean? But also translation into German and other languages was challenging. The revision to increase understanding across different cultures and countries became paramount. The review team therefore attempted to reduce the use of complex terms across the principle statements and keep sentences concise. Regarding the second theme, order of the principles, stakeholder feedback revealed that the PD principles were not seen as ordered or hierarchical. The review team found a new way of organizing the revised principles, moving from PD foundation level through different approaches towards sustainable transformation. On regular meetings, the review team discussed, reshaped and amended to ensure a contemporary re-envisioning. These revised principles were again circulated to a smaller stakeholder group for an external critique. Each team member provided further commentary alongside their suggested revisions, which culminated in the agreed wording for 8 revised PD principles. The Global Manifesto. The 8 principles evolved from the revisions made to the original 9, supporting a call for simplicity to facilitate early engagement with core PD concepts. Grouping the principles into foundation, processes, and transformational outcomes of PD provided a reordering as a natural development of the iterative critical review. Elements within the principles relate to the foundations on which transformational change is built, such as collaboration, inclusion, and participation. These have become more universal in an individual's or team's approach to PD, rather than relating exclusively to evaluation of PD activity. Whilst the order of the principles does not reflect a ranking as such, the importance of considering evaluation early on in a transformation journey was acknowledged, with this principle placed more prominently in the midst of the revised principles. Within the review process, the philosophical foundation of PD and its principles was a recurring issue. We see here Simone Clark and Chris White from the Sydney Children's Hospital Network, New South Wales, Australia, 2 colleagues from the review team. For this presentation, Simone and Chris have had a dialogue about the underpinning ideas, but for technical reasons, we now hear Chris only reflecting on the philosophical foundation of PD and the emerging principles.
What differentiates practice development from other ways of understanding health and healthcare is both the breadth of theoretical considerations and the depth of the contributions that are mined in the course of this greater understanding. I've got particularly in mind there human sciences, where particular elements of critical theory have been employed in health to a very fruitful conclusion that would have been unimaginable not that long ago. This all contributes to a greater understanding of health and healthcare and gives a much broader toolkit to the practitioners who are engaged in trying to help others understand their health and healthcare needs.
Hi, I'm Simone Clark here with our second example of the impact of using foundation principles in the Essentials of Care program. Essential Care is a statewide initiative currently in all local health districts in New South Wales, Australia. It is a facilitated process based on practice development principles and aims to enable change in patient, family and staff experience and care. It is structured around an external facilitator supporting internal facilitators from the ward or the department or the service that they are in to identify and celebrate what they do well and what improvements to patient care or workplace culture they would like to embark on. As a starting point, they undertake a values clarification on an individual and team level, bringing about the development of shared values for their team or their area. This provides a foundation for critical analysis of team behaviours and practices. They can ask themselves, do we work in ways that align with our shared values? And then they can go about answering those. Sets it up to be a good environment to critically reflect on what they're doing. With the Essentials of Care's structure of the internal and external facilitators, along with working in collaboration, inclusive and participatory ways, people become aware of their ability to enable and be part of change, regardless of their position in the department. Many internal facilitators explain their sense of achievement and confidence after having been part and having led change when previously they hadn't had that opportunity. Often change had
Thank you for the opportunity to share processes of practice development. My name's Beck Middleton. I'm thrilled to be able to share an example of practice development processes from some research I've undertaken in Australia aimed at determining the impact of undertaking a postgraduate leadership subject on practices in healthcare. The example I'm going to share is demonstrative of these two practice development principles outlined here: blending creativity with learning to free minds and achieve new ways of doing and being, and actively using workplace learning to transform people and teams. And when we consider these principles alongside the Venus model, sustainable transformation occurs using PD principles and person-centred facilitation. And this enables leadership development that impacts culture and innovation. While leadership development programs feature quite prominently in global literature, there's little evidence of the impact of translation of knowledge from past graduate leadership education to healthcare practice, in particular the impact on organisational culture, interpersonal relationships, processes and systems. So I was curious to explore how participants who completed my leadership subject up to 2 years previously had applied content and learning to their own leadership and practice, to their own context. What strategies improve articulation of theory to the practice setting? The subject extended to all healthcare professionals, and this provides opportunities for participants to collaborate, to learn from each other, develop networks to build leadership capacity and capability so that safe and effective patient care is led. The program is built on the philosophy that you don't need positional power to be a leader. Healthcare workers from all disciplines and positions can develop leadership skills to influence the culture of the workplace. The subject predominantly uses experiential learning based on adult learning principles. Participants are exposed to various models of leadership and leadership theory, and they're encouraged to explore their own values and beliefs to discover their leadership strengths and characteristics. Creativity is threaded purposefully throughout the subject in a variety of ways and also in assessments. And key is focus on people and how connection to others can occur in meaningful ways, underpinned by values of respect for others, because this facilitates the learner to authentically consider concepts and principles through their lived experience. What was exciting about the results was that it was evident the subject had an impact personally and at different levels in the organisation. There was clear evidence of translation of knowledge and skill into healthcare practice through completing the university postgraduate leadership subject. Clear reflection from participants revealed that the subject helped them transform attitudes through knowledge development. And this enabled empowerment of self and others through collaboration, through shared decision making, and transformation to bring about change. The participants interviewed, of which I'm sharing some of their voices, so these participants that were interviewed for the study overwhelmingly indicated that the subject enhanced and developed their leadership. They reported that they had developed a number of skills, particularly self-awareness of their leadership strengths, enabling them to engage others and have critical conversations. Clarification of their own values made them more confident to work with their team to develop a set of shared values and ways of working. And we know that shared values provides a basis for teamwork and collaboration, which are two features that can impact on patient safety. And so I just leave you for a moment to read the quotes from some of the participants. And I hope that you can see the connection of the interprofessional learning and support that generated such valuable translation of theory into practice.
We now look into the next two principles allocated to processes, and for each there will be one example from colleagues working in clinical practice. The first one, PD is a facilitated process that seeks to promote critically informed action. Achieving a process of transformation, whether at an individual or team level or across whole systems, requires skilled facilitation. Facilitation as a process of skilled negotiation, movement, and charting developments is central to critically informed action. Skilled facilitators maintain a clear vision of from where, to where, and how for themselves and those they work with. We now hear Corinne Auer, a clinical nurse specialist working in an acute care hospital in German-speaking Switzerland. She talks about her experience as facilitator, and she gives insight how she worked with the team on their annual objectives.
In the hospital I work, it is common to work with annual objectives. On the ward level, the nurses have individual and team objectives. Although the nurses are used to care for patients with delirium, they found the way they do it dissatisfying. They described it as always being a step behind and rather reacting than acting. Most of the nurses knew about the delirium bundle for prevention and treatment of delirium, but most of them didn't use it preventive. Also, most of the nurses weren't aware of the risk factors for developing a delirium. Therefore, the nurse manager of the ward agreed with the nursing team that their annual objective is going to be improving the care for patients at risk for and suffering from delirium. They asked me, the clinical nurse specialist of this ward, to support and facilitate this mini project. In a kick-off workshop, we shared how everyone is feeling when hearing the word delirium, using picture cards. Followed by this, we had a talk about what we appreciate in the current care for patients at risk or suffering of delirium, and about what could be improved. The nursing team agreed on their top priorities and the ways of working. The nursing team felt most comfortable with a small working group leading this project. 4 nurses volunteered. Within this working group, I provided literature, the internal guideline and resources, facilitated them to plan the next steps as well as how they could use the material. The members of the working group agreed on the actions to be taken and suggested it to the nursing team. In a team meeting, they agreed that pocket cards containing risk factors and the delirium bundle would be helpful, as well as case discussions every 2 to 4 weeks. Back in the working group, I facilitated them in creating the pocket card. Then we had a talk about how to plan and facilitate those case discussions. At the end of this annual objectives period, nursing documentation improved, the nurses were more aware of risk factors and used the delirium bundle earlier and more often. Furthermore, the nurses in the working group enjoyed the way they were facilitated and in turn also enjoyed facilitating the nursing team.
We now come to the principle PD uses inclusive evaluation to integrate evidence from process and outcomes of transformation. PD as a complex synthesis of strategies, practices and deftly applied processes marks its uniqueness and comprehensiveness. It encourages qualitative and quantitative measurement of the process of change. It insists that the stories of all involved are heard and included in the assessment summary, and therefore is universal and eclectic in its evaluation approach. The seeds of evaluation sown at the inception of the process enables as full a picture as possible of the then and now situations. Outcomes are transformative where they represent effective changes in practice, especially where they result from innovative processes. Another colleague of mine, Therese Hirsbrunner, works as a clinical nurse specialist in a mental health service. She talks about the ways of working on enhancing individual care planning.
In mental health nursing, individual care plans are essential. In a practice development project from 2015 to 2017, all 14 wards of a mental health service were involved with the aim to establish shared values on the nursing process and to enhance individual care planning. Every ward was represented in one of the 3 project groups by 3 staff members, one of them the ward manager. The monthly meetings of the groups were facilitated by 2 clinical nurse specialists and a member of the nursing management. In this process, the teams were enabled to develop and evaluate the nursing process adapted to their patient groups. The evaluation from the outcomes were developed in a participative way by the members of the project groups. They used methods as interviews with staff and patients, analysis of documentations or observations on the wards. For the evaluation from the process, space and time was provided in every project group meeting and at the end of every year for all project groups together in a celebration meeting. The photograph shows the Christmas tree created at the end of year 1 of the project. On every ward, facilitators are still working now with their colleagues to ensure a continuous evaluation of the nursing process and to provide coaching for their colleagues if necessary.
Having gained insight into the 2 foundation principles and 4 PD processes, we now move to the last section of the Global Manifesto, the outcomes. The first outcome, resulting from supportive relationships across individual teams and systems, is effective change, and I shall illustrate this shortly through critical companionship. The second outcome is the transformation of individuals, teams and systems based on using PD and a variety of different evidences, which I will illustrate through two initiatives. ACER accreditation, arising from an integrated clinical leadership program, and the Squire project, researching how to embed a safety culture in frontline teams. Critical companionship is a framework for mutual learning developed by the physiotherapist, practice developer and honorary nurse Angie Titchin. In the spirit of creativity, I've used the blob tree to illustrate this, where the concept is represented by the dyad sitting together on the extended branch. The model is used extensively in practice development to enable mutual learning relationships where we can learn with and from each other, inquire and experiment together, rather than a hierarchical relationship of expert and novice. Mansour Akhtar, a bowel surgeon, chose to have a midwife and nurse as his critical companion as he progressed through his leadership journey. The midwife was creative, passionate and a skilled critical companion who had worked with Angie Titchin in a number of workshops. She supported Mansour to grow and develop and to use the principles of critical companionship. This included a range of strategies such as high support and high challenge, creating a psychological safe learning environment, giving and receiving feedback, reflecting on practice. Mansour then used these processes of critical companionship and practice development with his own team members. Improvement both in team support and functioning resulted and was echoed positively in the audit results for the bowel surgery service. I choose this story to illustrate the first outcome, achievement of effective change through support, but it also illustrates aspect of the second outcome, transformation of the individual, the team and the service. Moving on to the second outcome, I will provide further examples of transformation. The second outcome, transformation of individual teams and services. Drawing on experiences of 4 different teams from an acute hospital setting who had participated in what is termed ACER accreditation, this stands for Achieving and Celebrating Excellence Recognition, and followed participation within a multi-professional clinical leadership program based on PD principles. The teams, a speech and language team, a microbiological team, a community children's physicians team, and a nursing surgical team. All teams excelled over various time periods through implementing their leadership and PD insights collaboratively with all involved in their teams and also service users. The ACER process involved working together to build a portfolio of evidence against the criteria for an effective person-centered and safe workplace culture. When asked to contribute to an imminent publication to describe their journey, all were adamant that it was a journey of moving from fractured to flourishing. Each team had become high-performing teams where all the members were leaders on some aspect of the team's purpose and function regardless of role, acting as collective leaders. The quality of the learning experience and the focus on being person-centered in relation to what matters to patients as well as staff was a key feature, and this benefited all parties with no challenges in retaining and attracting staff. Once recognised by the organisation, then opportunities resulted for influencing others across the organisation as these teams became known for their flourishing cultures where there was joy at work and a natural built-in approach to creativity and innovation. Transformation of staff and teams was demonstrated, including benefits to service users, and illustrated through various sources of evidence collectively gathered. Moving on to the Squire project, which set out to identify the strategies that embed a safety culture in frontline teams across 4 large acute hospitals in the southeast of England. This study showed that it is not possible to develop a safety culture unless we are also person-centered in our approach. The most important influencing factor in this is the quality of clinical leadership in frontline teams. That's the interface where care is experienced and provided. Whilst the study used eclectic methods, including emotional touch points, to understand what worked, one method was observations of practice, which was undertaken between the researchers with staff. The qualities of a person-centered culture were observed in a range of different observations across all the 10 teams involved. Some of these are presented on the next slide. These observations were drawn from using observations of practice across different sites where person-centered moments were linked to patient safety. Reading these observations provides powerful insights that we need to reflect on. Having illustrated all the principles from the Global Manifesto for PD, we would like to conclude with a focus on the relationship between practice development and other improvement approaches, such as quality improvement, lean service improvement, etc. Reminding you about our title, It is the Way You Do It, I would like to draw on the experience of 2 PD facilitators involved in maternity transformation, a midwife and an obstetrician, who share their journeys within the pending international textbook. So what is the relationship between quality improvement and practice development? In the words of an expert midwife and practice developer working in service improvement with a long experience of using lean methodology, Crystal explains that she knew what was needed to be delivered, but was left to define the why and the how with the teams and individuals in the lean program. In the Squire Safety Culture Project, we experienced this too, where organisational facilitators were encouraged to use tools such as Texas Team Safety Tool with practice teams, but once getting a result, which is always incredibly difficult with busy frontline teams, didn't then know what to do with the results to move forward and harness the team's untapped abilities. Whilst a wide range of skills are needed for learning, improving and developing, most essential are the skills in enabling engagement, participation and a sense of meaning with all key stakeholders. These insights are illustrated in the quotes from our maternity duo based on working with other approaches and presented on the final slide. Crystal reflects on and recognises that after responsibility for delivering a lean program, the active work-based learning facilitated her transformation, and this acted as a turning point where she truly recognised and understood transformational PD. And Kieran Crowe, our obstetrician practice developer, a rare beast, explains his eureka moment. It is vital that we use scant resources diligently by not duplicating or siloing our improvement approaches, but by complementing each other with the skills in a way that will enable sustainable change and transformation. Practice development is about co-creation of shared values and purposes, and it is these that guide direction and decision-making, linked to both the evidence base and the key principles of collaboration, inclusion and participation, shaping workplace cultures that enables person-centered practice. So we have come full circle to the Venus model, where we have profiled practice development and alluded to its powerful interconnections with the other arms of the model. Greater integration between practice development and other improvement approaches, mirroring an integrated approach to health and social care that can only benefit all through making a case for collaborative learning, development, improvement, research and innovation. We provide here some of the references we've referred to during the presentation and look forward now to discussing with you your feedback, comments, ideas that we can then take forward together. Thank you.